for health and social care. I'd like to say a big thank you to our guests for attending today. It's nice to see you all. And thank you to the councillors as well. Before I get started, I'm just going to run through the fire procedure really quickly. So there are no planned fire drills during this meeting. If you hear the fire alarm, please treat it as a real emergency and evacuate the building via the nearest safe escape route. The nearest safe escape route is via the stairs to your left as you leave the council chamber or public gallery. Exit via the door at the back of the building and walk across the inner car park to the evacuation point, which is the pavement opposite the police station. The lifts can't be used in the event of emergency, and please do not re-enter the building until you advise it's safe to do so by a member of staff. Okay, so apologies and changes in membership. We only have one apologies today from Councillor Lever and everyone here. Minutes. So I'd like to confirm as true record the minutes of the meeting held on the 2nd of September. Does anyone have any points to raise on the minutes? Okay, can I have a proposer for that? And a seconder, lovely. And we're all fine with the minutes. One. Okay, declarations of interest. Do any of the councillors have any interest they might want to on the agenda?
Thank you, Chair. On this agenda, I'll declare a non-pecuniary interest in the issues on dentistry. Thank you.
Thank you. Anyone else? No. Okay, so we'll start with public question time. I believe that we have a question. Is the member of the public in the gallery? Would you like to read your question loud?
Good evening. As of the 8th of November this year, the list of pharmacies on the website, the council's website, has still not been updated, and there appears to be no evidence of any press release having been issued giving guidance to members of the public regarding the supply and disposal of sharps bins. So I would like to ask what meaningful actions have been taken by the council's strategic director of community services or delegated officers since the 2nd of September 2024 in relation to these assurances, and what tangible outcomes have been achieved.
Thank you, Mr. Knowles. Thank you for coming and chasing up this issue again. I know you've been here a few times. So we don't have the person responsible here to read their response, but I will read it for them. The Isle of Wight Council Waste Team has drafted a service level agreement, an SLA, and has liaised with the pharmacies lead to confirm the services to be contained within that SLA. When complete, it will include any pharmacies willing to take in larger sharps bins, as well as 1 and 2 litre sharps boxes and cytotoxic medications. Until this formal agreement is in place and our waste service provider is informed of any amendments to the current list of pharmacies that they collect from, we cannot in good faith issue a joint press release and update the web pages. Some of the pharmacy names that have changed management to J Hoots, is that Boots? Oh, it's Jutes, and are still in the same locations. A request has been made to change those on the website as the addresses are the same. This should not inconvenience customers. Furthermore, we have been, apologies, been made aware of some closures that will also be updated. The website has been revised as it was noted that a previous update had accidentally deleted the line. If you have a 5 litre or 7 litre sharps box that you're unable to dispose of at any of the participating pharmacies, please contact the waste team on 01983 823 777 or waste.contract@isleofwight.gov.uk. This has now been restated. Mr. Knowles, would you like to have a follow-up question to that response?
According to the website, yes, the Jutes pharmacies have been altered, but it still logs Sainsbury's as having a pharmacy still in place. And I think it's been more than a year since the pharmacy closed. in Sainsbury's. So is there any indication of when the new arrangements will be in place that will take over from the interim arrangements that no one is aware of via the press release that was promised 6 months ago?
Thank you, Mr. Knowles. We'll provide you with this written response that will be sent to you, and we'll put that question to Colin Rowland and his team. And I'd like to thank you for keep coming back and talking about this. It's been going on for quite some time, and I can understand how frustrating that must be for you. So we will send your question to them and give you a written response. Thank you. Do any councillors have any comments on that topic before I move on?
Sorry.
I just wanted to say it's really disappointing that it's taken so long to get this resolved. And it would be, I agree with the gentleman, it'd be really helpful to have a time scale. So when exactly will the SLA be completed, and when can we expect a press release? Because I did contact the department at the beginning of the year to indicate that some of the pharmacies were incorrect, and yes, one of them is in fact closed, and yet people are still being directed to that pharmacy on the website. So timescales would be really helpful. Thank you.
Thank you, Jo. Councillor Spink.
Thank you, Chair. I was just going to say that it is on our agenda. So if the member of the public, I'm sorry, I didn't catch his name, but if the member of the public wishes to stay for a little while, it is on our agenda under outstanding actions. I was going to say a couple of things during that. So shall I wait for that rather than now, or how do you wish to deal with it, Chair, either as a under public questions or as the agenda item?
As we're discussing it right now, you're welcome to raise points now.
I mean, I was at that meeting where there was extensive discussion on the disposal of sharps, and from memory, it wasn't limited, I don't think, to simply further information about larger boxes, as it were, disposal, which is what the answer seems to be suggesting. And there seemed to be general lack of knowledge by members of the public, not their fault as far as I could see, about just how they should dispose of sharps generally, and that going to certain pharmacies they were, as I understand it, turned away from. So I do think the press release, if they're waiting, this service agreement is waiting to clarify larger quantities and larger waste boxes, I would have thought that the information that was requested in detail at that meeting on the 2nd of September could and should have been dealt with by now. I can't tell you each and every thing that we discussed because it's a couple of months ago now, but there was a fairly broad discussion. To the best of my recollection, it wasn't limited to large waste boxes. Thank you.
Yes, I agree with you. And also, I believe when we were discussing a press release, it was not so much about the SLA, but what is the process at the moment, and what do we expect? What can residents do at the moment, regardless of whether or not the SLA has come into action yet? So I think a press release can be issued ahead of that time, and perhaps that's something that we should go back to Colin and tell him and his team. Is the committee happy with that? Yes, John.
Can we ask for the press release? What I understood, because we've been dragging our heels on this for some 2 years now. Can I request that the press release gives details of what to do now, i.e. to contact waste services, because that is the only means of getting rid of 5 litre and 7 litre sharps bins.
Chair, could I also say, given that at the very least now that was actioned on the 2nd of September, and here we are now 2 months later, and as Councillor Nicholson says, it has come before the committee before. Could we perhaps put a time limit on when the press release should be issued? And I was always taught in my previous profession that if you didn't deal with the first time limit, the second time limit got progressively shorter to make you deal with it. So I would suggest, please, a press limit within 14 days.
I'm happy to recommend that. As any other thoughts from the councillors on that? Happy. Okay, to summarise, so we will go back to Colin Rowland and his team and request that a press release be issued within 14 days stating what. Oh, sorry, Debbie. Yes. Before I finish, you can carry on, Debbie.
Sorry to interrupt, if it's helpful. I think my understanding is the storage capacity. Apologise, and I accept that that the populated list of pharmacies should be accurate. But it was my understanding it's not the smaller size that is so much of the issue. It's the 5 litre and the 7 litre that the pharmacies don't have the capacity to store necessarily, which is why there is that option that if any residents are having issues, they can contact our waste team directly. I just thought I would add that. I think it's more of a storage issue.
Yes, and that's fine. I think what the gentleman is wanting is that whatever the pathway is, whether it's contact the waste services, that it just be communicated to everyone, and that that press release just say that, which I think is simple enough to do, and I would hope that we can issue a press release within 14 days that says that. So we'll take that as an action. Is everyone happy with that? Councillor Jarman.
Thank you for your indulgence, Chair. Thank you for reading out the correction on the website regarding the collection service. I wonder whether you could also inquire if they will be making a similar change to has been changed. I'm not too sure if the other reference has. Obviously, it affects people who are able to go to a pharmacy.
We can certainly include that. Thank you, Councillor Jarman. I think we are done with that topic, so we'll move on to the next one, unless any of the council have anything else to add. Thank you very much. And thank you, Mr. Knowles. Okay, agenda point 5, progress update, pages 9 to 10. We've got 3 items on the progress update. The top one being dentistry, which is on the agenda this evening, the 5 litre sharps bins, and then a question on suicide prevention awareness. Do the councillors have any comments on the progress update? Yeah, Councillor Nicholson.
Another old chestnut, Chairman, accessibility standards. I think most of the committee receive regular phone calls from Isle of Wight patients who are registered for large print and they're just not getting them. I think the latest service now not to do it is chiropody. Am I right, Joanna?
Yes, we've had, I've had a conversation with the same individual, and yeah, he's been getting small print letters regarding his appointments where he can't see them, and it's been going on for quite a while. And yeah, other departments will issue large print letters, and it certainly impacts quite a few people on the island and their ability to get to the appointments if they can't read the instructions or the time.
Thank you. Councillor Nicholson, were you requesting that be put on the?
Yes, please.
So we'll take that as an action to bring the accessibility standards back onto the progress update. Is that okay? Yeah. Are there any other comments on the progress update? Yep, Councillor.
No, just following on from Councillor Nicholson, Chairman. I've had numerous calls from a certain gentleman, and it's just not good enough. These departments it's not beyond the wit of them in all these complicated emails and stuff and all this language that nobody can understand. It's not beyond the wit of them to actually make it available in small print. It's not rocket science, in large print, sorry. It's not exactly rocket science, is it? That's my comment. Thank you, Chair.
Thank you, councillor Downer. Yep, Chris.
Can I just pick up on what Joanna said about the size? Is it possible to have a minimum standard, say of a 12 font, as any documentation coming out from health, social service, or whatever it happens to be? At least that's a basic level. Clearly, you still need probably 18s and 20s for some people who've got very difficult to reading, but a minimum standard would be a starting point.
Is that directed at, would that be directed at our health partners? I'm conscious that we do have a agenda point later on about the partnership between Portsmouth and Isle of Wight. So it might be appropriate that we discuss that on that agenda point. But you also mentioned about social care as well. So I wonder whether that's a question to put to Laura as too.
I can confirm, Chair, that the local authority's position is we try to avoid sending post wherever possible. Given the current financial constraints that the local authority faces, we tend to communicate by electronic means with anyone who will accept communication in that way. That then gives the recipient the opportunity to amend and resize the text we're sending them to meet with their specific needs and their specific purposes. Simply holding the right button of your mouse and scrolling up enables you to magnify the text yourself to meet those specific needs. Where an individual has identified to the local authority that they have specific requirements in terms of accessibility of information, that is correlated with their Paris record, Paris being our current case management system, and that will automatically flag for anyone who's communicating with them the need to provide material in a different way. No system is foolproof. The electronic version gives the individual far more choice and control over how they access the information we're sharing with them, which is another reason why that's our default mechanism for communication now.
Thank you very much, Laura. Does anyone have any comments on that? Are we happy to move on? Okay, thank you. Okay, so that takes us to our first agenda point of the evening on dentistry. So in your papers, you would have had a dentistry update report, but I will pass over to James Roach, who can give a summary on that for us. Thank you very much, James.
Thank you, Chair. And for those who haven't met me before, I'm Director of Primary Care at the ICB, so I also cover general practice, optometry and pharmacy. You've got the paper in the pack. I'm just going to take it in three ways, if I may. The first one is progress against the challenges we're facing. The second one is a bit of a view on what's happening nationally, how that affects what we do locally. And I'll probably end the paper just by talking about what I think we can do together. And I talk about that in the context of the meeting we've got in January, where we aim to present the Isle of Wight strategy for dentistry. And I really want to have a conversation around how we can co-produce that and work in partnership with our local communities. So I'll start with access. We've got 172,000 UDAs targeted for the island this year. And we have seen an increase in the number of UDAs that have been commissioned. So we have gone beyond 30% of available UDAs commissioned for the first time, I think, certainly in the last 2 years. So that's 32% for adults. And we have seen an increase in children as well, to about 41%. Again, I'm not sitting here complacent suggesting that we should celebrate that. What I would like to highlight is the progress we are making in sort of extending that access. I think the second point I'd like to make is, in addition to our core delivery, we have commissioned a mobile dental unit. And since I was last here in September, we have commissioned additional clinics on the island to this date, and also moving forward to the end of March. So between now and the end of March, there'll be another 40 mobile dental unit clinics on the island. And just to give you a flavour for the number of treatments to go through the mobile dental unit, year to end of September, circa 1,500 treatments. And when I talk about treatments, often they're the most complex, because these are people with a significant dental need, a significant level of urgency, and are often type 2 and 3 of the dental treatments that are reflected in the paper. So we would expect, on the basis of the average to date, to see another 800 treatments through that service before the end of March. So again, progress through the additional activity that we're commissioning. And I would hope that members around the table would see the increased number of clinics on the island as a positive step. And I gave a commitment last time that I would increase that, and we've increased that by another 40 to the end of March. Again, I don't sit here saying that that's the longer term solution. We've had to be innovative to meet need because we recognise that not just on the island, but across Hampshire and the Isle of Wight, there is a shortage of NHS dentists. And we've had to be innovative in terms of how we provide services. A couple of other things I'd like to highlight, because I think it's relevant to the points that were raised in September. One of the longer standing issues I think we've had on the island has been the UDA rate and the UOA rate, and that's the amount of money we pay per unit of dental activity on the Isle of Wight. And we all recognise the challenges with the coastal community. We all recognise some of the challenges in terms of recruiting and retaining NHS dentists. And as you can see in the paper, we have increased the UDA rate on the island. And I'm pleased to say that we took a paper through our governance last week, but that will be increased for another 2 years moving forward. So again, I think that demonstrates our commitment to invest in line with the needs of the Isle of Wight, the coastal communities and the challenges that it faces moving forward. The other thing which I think is a positive step and reflects our ability as a commissioner to both react to local need but plan for the future is we've put out a public procurement exercise to commission an additional 68,000 UDAs for the island. So that's just under half of the current number of annual UDAs that we commission. So we're looking to uplift that on the island by circa 45 to 50%. I'm pleased to say that we held a bidder event in early November and we had 4 really strong providers on that call. My judgment, and I've got to be careful what I say because we're in a procurement exercise, but I believe in that selection we have providers who are able to service that demand and perhaps more importantly are committed to providing NHS dentistry on the island. The other things that have been in our control that we have acted on is you'll be aware of national initiatives around the NHS contract for dental, and I'll come on to that in a second. But one thing it's enabled us to do is to use vehicles such as the Golden Hello. So again, we recognise there are challenges often in recruiting and retaining NHS dentists. We've made sure that the Isle of Wight has been at the front of the queue in terms of the ability to access that national money. And a number of our NHS dentists on the island have used and are using Golden Hellos to recruit and retain staff. The other point I'd make in terms of local commissioning is you'll all be aware that we had quite a high profile contract handback in freshwater a few months ago where a private provider, My Dentist, decided it no longer wanted to provide NHS dentistry on the island. Because we've got closer control now of commissioning, because we are acting locally in line with local needs, we were able to address that issue head on, deal with it, and ensure that there was a local NHS provider in place within a 4-week period. And I think that's fairly unprecedented in terms of what's happened before and how that's been commissioned. Councillor Jarman's in the audience. He will know because he's obviously the member for Freshwater. There was a lot of public interest in that. There was a very high profile petition. Really praise the local community for the support they've given the dentists that remained in situ. And those dentists are now working for the new NHS provider in the area as well. So I think, again, from that challenge, we've at least showed an ability to address that locally and put issues in place. A couple of things just to be aware of. I do often talk here about the national contract, and we do recognise the need for reform of the national dental contract. What does that mean in real terms? I mean, ultimately, it means that sets the amount of money we can pay on the UDA rate. And even with the progress we've made in uplifting the rate for the island, I think the general view from professionals and other stakeholders is that needs to be higher, and that higher rate needs to stay for longer. So we continue to lobby through NHS England through our routes, but I'm pleased to say that we've had the support of both MPs on the Isle of Wight in doing that, both Richard Quigley and sort of Joe Robertson as well. And I believe they have made or are making representations to the Health Secretary, which again, I think is a reflection of the need on the island, but the willingness of politicians to support on that solution moving forward. Just in terms of the paper, I think I'll take most of it as read, but I will point to a couple of other areas of development and things we need to be positive about moving forward. You'll be aware of the case for a dental school in Portsmouth, and that's likely to follow the model that's currently in place in Liverpool. in conversations with the Dental Academy, the aim is for that case to be submitted in 2026. And we're really clear that whilst the dental school will be on the mainland, it's really important that there's a facility and a connection with the Isle of Wight. And we've already had conversations with those in place at the Dental Academy around how we can develop a satellite site on the island, how we can develop a stronger route, if you like, between NHS dentists on the island and education. And when I talk about that, I don't just mean the dentist. And I think I've said before, we've got really good dental nurses, hygienists, technicians that we also need to support in role and make sure that we're getting more and more into the profession moving forward. So that's the sort of the main update in terms of what's happened since last time, the challenges we've got and the progress we've made. I think my last point, Chair, would really be just a quick comment in terms of where we can work together. So I did meet with Councillor Andre, I think in September, and we talked about the need to try and do something different around workforce and planning for a future dental workforce. So one of the things I'm really keen to do as soon as it's possible with the committee support is to look at whether we can have a workforce summit for dental on the Isle of Wight. I've seen that in other areas and that's worked well. And I think that's something we can build on. We need to do more around oral health promotion. So Denby House is an example of a practice where dentists have taken responsibility to go out to schools, to go out to education establishments and educate children around oral health promotion. I think we need to be more ambitious and do that on a greater scale. And again, I think that's something that we can work on together. As you know, dentists are independent businesses. And I think it's also really important that together we look at what support dentists need to remain sustainable financially. Some of it is about their level of reimbursement. Do we need to look at rates? I know some dentists have spoken to me about increasing commercial rates, etc. But also look at whether dentists on the high street can access support for capital development. And is there more we can do together to sort of support our dentists moving forward? And I think the other thing, just referencing again, the good work in freshwater, is whilst we've had a lot of interest from our community, there's a lot there I think that we can tap into. I think with Health Watch's support, we can engage differently with our community around dentistry. I think we can create a strategy that far more reflects the realities of the island. And what I'm keen to bring back in January is that Isle of Wight dental strategy, not just for this year and next year, but something that can set us forward for the next 5 years as well. So I'll stop there and I'll take questions. Thank you.
Thank you. Thank you very much, James. Do we have any questions from the committee? Yep, Councillor Drew.
Thank you. Thank you very much. That was really helpful. Just fielding a couple of questions from constituents. I know that they obviously welcome the fact that more money has been going towards dentistry on the island and the UDA rate increase. So presumably the limit for that is stipulated by statute. We're at the top amount of the sort of the excess that we can put on that UDA rate. That's correct. So we essentially we need to lobby government if we wanted more money, if we wanted to push that. Is that correct?
Yeah, I need to lobby my finance director, so I'll do what I can. But yeah, I think some of this is about how we lobby government as well. And this is why flexibility around commissioning is so important. And I think where you can help is really articulating the challenges around coastal communities in terms of recruitment, retention, and average unit cost as well. So I think through both MPs, there's a commitment to do that. But any examples you have locally, whether that's from patients or professionals, that would be really helpful. And I think one of the things we will outline in our dental strategy is where we see that going over time. And because we're engaging now with the NHS dentists that we've got a better indication of those business realities. We want to set her in line with those realities if we can.
Thank you. So just to be clear, then there could potentially be a little bit more, as it were, wiggle room in what the UDA premium would be. Is that correct? Is that fair to say?
So I think currently, if you look, and obviously we commission dentistry across Hampshire and the Isle of Wight, the UDA rate for the island is the highest by some margin. So I think we've also got to look at equity and balance on that. But I think you'd be assured we're doing all we can to flexibly address that. But what we do need is reform of the national contract to give us the ability to do that over more than 1 year. My concern at the moment is we're commissioning an annual cycle, but we know that growth in demand is going to be there for the next 10 years. We need to commission for the next 5 to 10 years to really give dentists an opportunity to plan services and grow.
I may just with a very quick follow-up. So in terms of moving forward, I know that some ICBs have been looking at sessional type arrangements whereby essentially a dentist is employed for a certain number of hours and they will supply as much provision within that time as they can. Is that something that would, a model that would work on the island? And if not, why not?
So we are looking at a longer term procurement. So I'm confident around this additional 68,000 UDAs. One of the things we've been asked to do by NHS England is provide a plan on where we can increase dental activity over and above the contract. So a key line there is the additional hours scheme. So we've mapped what we think that will look like between now and the end of March. And that's dependent on NHS England providing additional funding through that route. So that gives us the ability to use sessions more flexibly in line with demand. The challenge we'll always have on the island is we haven't got flexibility in terms of the number of NHS providers. So we will be operating within a very challenged pool, but we have put a case there in terms of what that could mean in terms of provision here.
Just very quickly, I won't try to dominate this as much, but so in terms of that sessional amount, is there a limit to what we would, I mean, essentially this is just a money problem. Essentially, you know, we need to stuff their mouths with gold, to echo, you know, Nye Bevan's comment. I mean, when you can work for the private sector and, you know, taking on an NHS contract is so porous in comparison, that's how it's solved on the island, to just simply to increase that amount considerably. Can we do that on a sessional basis, or is there limits in terms of, again, I suppose the equity that you mentioned in relation to the rest?
So yeah, I think equity is important, but I think this latest development from NHS England gives us the opportunity to create a pool of sessional UDAs that we could draw down wherever there is need. So I think nationally they are looking at that. What else can be developed? In the same way we would commission additional GP hours to meet on the day demand, or additional doctor hours to meet a particular challenge. We need to do the same in dentistry. So I think this is why NHS England are asking for those bids, to see if that's something that could be mobilised nationally.
Otherwise, we need to be lobbying NHS England. That's sort of where we should be directing.
Yeah, together though. I would suggest we do it together, because I think that's why the Isle of Wight dental strategy, and this committee did ask for a Isle of Wight dental strategy, and that's where I'm committed to. We have to make that real and reflective of the challenges that we've got, and use that vehicle to lobby up. That's helpful.
Thank you. And before I move on to Joe, can I just ask you to clarify just quickly about what Councillor Drew was referring to in terms of sessions, just for clarity, so I understand. Thank you.
I think Councillor Drew could articulate it better than me, but I think it is what it is. It's additional sessions over and above contracted hours that we can flexibly commission to meet demand in the particular area.
Yeah, my understanding was essentially that rather than working on a unit basis, it's essentially that they would be employed on an hourly basis. So, I mean, I think, you know, the issue, I think, very well articulated in the report at page 17, where it sort of goes into the detail of what would happen if you were having a root canal treatment, and there would be a series of other treatments as well under the UDA system, that you would only, an NHS dentist would only get paid for that top line treatment, whereas obviously in the private sector it would be all of those parts. So my understanding would be that a sessional basis might overcome some of those issues with what is essentially the contractual problem, that it's just not fit for purpose.
Thank you. Thank you for helping me understand. That's really useful. I'll move on to Joe, and then Laura, then Rodney, then Councillor Spink. So Joanna.
Thank you. Just a couple of comments. In the report, it would be helpful if you detailed the Isle of Wight data rather than the Hampshire and Isle of Wight, because I'm aware that access across Hampshire and the Isle of Wight has increased, but access for adults on the island has decreased slightly. And I'm guessing that's probably related to the oral health of people being particularly poor to start with. So more UDAs are being used per person, which explains the increased UDA rate. But also, we're really pleased about the progress that's been achieved so far, because for so many years there was nothing and the situation was just declining. But I would say there's still a long way to go. I would say that I think the success of any plans will be down to engaging with dental providers and with people on the islands, because you were quite right in that we need to do more around prevention for, and we need to work with mothers, pregnant mothers, giving support about what they can do as soon as their child gets teeth. And there's stuff that we can all do without having access to a dentist. Just got a question about dental students. So are you working on more practices being able to support dental students on the island? Because I know that's a big problem with just one practice able to take students on at the moment. Is that something that you plan to work on?
So there's another provider, I won't mention them, but they're also potentially a provider of more UDAs in the future. And I believe they've already made representations to the Chief Dental Officer about how they could have a similar status to enable them to attract trainees. I think it's going to be more relevant for the island once the Dental Academy is established. We've almost got to create that relationship, I think, in terms of exchange and sort of placement as well moving forward. I think Denby House is a practice that does attract and use trainees, but we need 3 or 4 more Denby Houses, I would suggest, to get us on a stable footing. And that's what the strategy is about. How do we grow from that base through more UDAs to create a more innovative service model? And again, I think in time it would be good for the dental academy, the dental school plan to come through this committee, to get the committee support as well, because I think it's another key development for dentistry, not just here, but across Hampshire and the Isle of Wight.
Thank you. Laura?
Thank you, Chair. I'd like to just extend an invitation, if I may. A lot of James's comments in relation to workforce really resonated with me as the chair of the Isle of Wight system combined workforce board. And James, we've already linked in around dentistry in relation to that, but just an offer to ensure that as part of the strategy development workshop that's taking place next week, those dentistry asks are really pulled forward so that we can ensure they're part of our island strategy.
Thank you, Laura. Councillor Downer?
Thank you, Chair. Yeah, I'd just like to ask, and apologies if I've got this wrong about all these UDAs and things. Now, when people go to the dentist and they've got access, does it all depend if the dental practitioner has used up so many UDAs on one patient and then another patient uses all more up? How is that going to achieve dental fitness? Because if he's used all his UDAs up, they can't go back and be treated again for follow-up, can they? Does that make sense?
The question makes sense, and maybe I should have explained it better. So there's a total number of UDAs we commission for a population, and then each dentist will be able to bid for a number of UDAs in line with sort of service activity. We don't place a cap on number of UDAs per patient, but I think the point you were making, Joanna, is the average number of UDAs may be higher for some patients based on need versus others. So it wouldn't disadvantage patients in that regard. I think the key message I can give is that we do track UDA levels of those dentists. So if they are looking at like they're going to go beyond their contracted rate, we do have the mechanisms locally to uplift it and go to 110% of contract value, for example. So what some of the things we have done is where we know a dentist is going to meet their target, we've then created a decision whereby we can extend their provision to 110% of their value and volume, so they continue to provide treatments, but it doesn't disadvantage the individual in that regard.
Someone else. Sorry, I do apologise. The thing is that just for acute, or you know, are they allowed to go back to those clinics, patients?
Yeah, so it is people with the highest risk of poor dental health. And often, if you look at individual cases, some people are presenting with really severe dental issues. And I think, again, Joanna's point in terms of often you find the average number of UDAs for those patients is quite high because they've got a level of complexity. There's very clear criteria in terms of eligibility. And then once you're eligible, the idea is to meet your dental needs in that appointment, stabilise, and then hopefully get that individual into an NHS dentist moving forward, or into a plan. I think, Chair, what other select committees have asked in other parts of Hampshire and the Isle of Wight is for more information on the mobile dental unit, some examples of the type of treatments they're providing. And I've also got here the clinic list, which I think will be helpful for members, just in terms of when the mobile dental unit is in their area, whether that's an opportunity to visit it or have a conversation with them. But as I said, we've got another 40 clinic days between now and the end of March. Members would be very welcome to attend that and see the work that it does.
Thank you, James. I think we'd certainly take you up on that offer. Thank you very much. Councillor Spink.
Thank you, Chair. 2 or 3 questions and comments, if I may, please. Do you know, in percentage terms, how much of the UDAs, so for, say, a standard filling, do you know the percentage difference between the average private fee for that and the average payment for under a UDA contract?
So again, good question. In the paper, page 3, we break down the sort of the NHS band charges, if you like, the UDA rate, band 1, band 2, band 3, and ultimately band 3 would be your most complex conditions. Band 1 is likely to be a checkup. Band 2 may well be a fill-in or an appointment pre a fill-in. So we've got an understanding of what we pay on an average basis. It's often very difficult to pin down on average what private providers charge, because it will differ in terms of their business model, levels of demand, and where they're located. But there has been some comparisons done nationally. Happy to find that and share that. That would be helpful.
That would be helpful, because it seems to me, and the committee has already expressed this really, that until the UDA rates go somewhere nearer, somewhere closer to the private rates, unless you get a very charitable dentist, which may or may not exist, they're not going to take on the required number of NHS, as it were, patients. So I think that needs to be looked at. And also, I entirely agree with Councillor Drew that this idea of the UDAs only paying, so I think the example, and I can't find it now, it doesn't matter, but the example in the papers is that if a person needs a root canal and a filling and a crown, the dentist under the UDA only gets paid for the crown, that being the most expensive part. Well, I mean, you know, it stands to reason that if you don't pay someone for the work they've done, and in any event it's not at the rate they want, that's the nub of our problem. And with great respect, I'm sure you know, but that's what we should be lobbying about, it seems to me. The other thing is just an observation that in a previous life, I was a criminal lawyer, and our professional body made us take legally aided work as well as private work. And we weren't allowed. So if a case came along, and in this case, it would be a member of the public who needs dental work, we couldn't turn them away on the basis that they were publicly funded. We had to take their case. And that meant that members of the public got access to the best barristers. KCs, for example, had to take legally aided work. Now, it may be that that was imposed by our professional body, and it may be that because we were private businesses, as are dentists, that the government, as it were, can't impose that, but their professional body could. And is that something that would be worth lobbying for? We were also encouraged as lawyers to take pro bono work. So, I mean, if you've got a practice that is making a substantial amount of money, and let's face it, privately paid dentists do, then, you know, a moral campaign that they should take a percentage of pro bono work wouldn't be unreasonable. And by NHS work, I don't, for example, think it should include cosmetic dentistry, but it most definitely should include, I'm horrified really to think that is anyone who's pulling out their own teeth or things like that. We're a first world country. So those are the 3 points. The other final point is this, that we're talking about lobbying our MPs and that our MPs have helped, and I'm grateful to hear that. Is it appropriate, does the committee feel, that we ask for a report from our MPs in writing on what they've done on this topic for it to be delivered in time for our next meeting with chapter and verse? Because I don't know what they've done. And I have to say, I have written once or twice. I'm not going to say to which MP, never had a response, not on that particular matter, but on related matters. So it'd be nice perhaps if we could call them to account. So I don't know if you could just comment on those various points.
Yeah, last point. Yeah, that of course would be helpful. In terms of, I suppose you talk about obligation. I think the challenge we've got currently is there's no obligation for a private NHS dentist to take on NHS patients. There's no minimum requirement in terms of volume. And I think we've even had issues in freshwater where, unfortunately, some patients were left treatment in situ, if you like. And if it wasn't for that NHS provider stepping in freshwater, we would have had quite a lot of patients who were mid-treatment with significant issues. So the challenge we have is there's no real obligation on private providers to maintain their NHS provision.
I appreciate that.
Yeah.
And that's why I suggested perhaps lobbying the professional body, their regulatory authority, to see if they could say that, a dentist should have, say, 10% or whatever's thought appropriate financially of NHS patients, not simply all private. The other final thing I was going to ask, and I'd forgotten about it, is that the freshwater or the Denby model seemed to be a very successful model that I've spoken to Councillor Jarman because we're in both in the same area in the West Wight, although it wasn't in my ward as such. Is that a model? I mean, it seemed to be sorted out relatively quickly and provided a solution. So is that a model, a business model, or whatever one wants to call it, a professional practice model that one can start applying elsewhere? So you, with the help of various people, were able to put in place and save a dentist's surgery. So if you know areas that haven't got surgeries that take NHS patients, is it possible to use the Denby business model and be proactive and go and set up new surgeries there?
So I think the key lesson from the freshwater example is a lot of the solution there was very much based on goodwill and relationship. So we had a good relationship with that provider. We were able to work with them, so they were able to step in. I think there was a lot of goodwill from the local community and a significant amount of goodwill from the dental team that were in place because they were facing a lot of uncertainty in terms of their future, and they had to be very patient in that regard. So I don't think we can continue to survive on a model that is based on goodwill, best intention and relationship. I think ultimately what we've got to do is learn from that and make sure we're commissioning more UDAs across the island with a core group of NHS providers, and Denby House would be one of them. I think where there is a lesson is how we build on the fact that dentists are an important cornerstone of their local communities. How do we build that model that supports them as a community entity? But I think we've got to be really clear what our responsibility is from a commissioning perspective. I think we've got to commission more activity and make sure it delivers in line with expectation. I think where local communities can help in terms of signposting, messaging, things like oral health promotion, looking at where the local community can support with facilities and support for new workforce and that type of thing. So I do think there are lessons from the freshwater example that will be reflected in the proposed dental strategy for the Isle of Wight. But I don't want people to think that we're taking a step back from our responsibilities. That was opportunistic in terms of relationship, goodwill, and local intention. We've got to make sure we commission models that enable the community to have confidence in and can support moving forward. But I think, Councillor Jarman's in the room. I think the work the local community did there was exemplary. And that's not something we want to maintain moving forward in the right way.
Microphone, but may I just ask one more question? And that's this. There's been mention of, I mean, a lot of dentistry work, once a person's teeth are in reasonable and gums are in reasonably good order, there's actually shouldn't be too much work thereafter. And that depends really on good cleaning of your teeth effectively. Is there more that could be done to have within the education system some discussion with children, and also children up to the age of about 10 won't voluntarily clean their teeth. You have to say to them, come on. So perhaps even if there's like a lecture going on at school, perhaps parents, if they've got the time, could come and be encouraged to help their children. The other thing is, I mean, dentists, you know, even those things, those TP things that go in between your teeth, they're jolly expensive, particularly to a family with, say, 2 or 3 children, and the families mainly on benefits. So is there scope, because they're expensive to a family, but in the greater scheme of things, not expensive to the NHS. So, for example, at those discussions or those lectures, or whatever you want to call them, you know, is it possible to perhaps even hand out a supply of those sort of things so that the children get used to using them, the parents get used to helping the children to use them, and that in the long run might A, help, and B, cut down the cost. Thank you.
We are investing in oral health promotion, so I think it is school children, but also it's adults as well. So one of the things we might want to do with the mobile dental unit is what happens once the individual's condition is stabilised. We then need to move them into a form of oral health promotion or education so they can better manage their own dental health as well. And again, that's something we'll reflect in the strategy. The issue around oral health promotion, again, is that happens because that dentist has taken the initiative and gone out to schools. We need something that's a lot more collaborative in partnership with public health and other organisations so it becomes mainstream.
Okay. Yeah, sorry, just to add to that, totally agree that it links really nicely into the poverty reduction strategy, because dental products are last on the list if someone is struggling to buy food for their family. And I'm aware that a lot of dental practices used to get a lot of free produce. So I wonder if we could work more widely with both NHS and private dental practices to utilise some of their freebies that they're getting so that they could go to where they're needed. And I know that Denby Dental House does share their products with schools. Perhaps we could encourage other dental providers to do the same.
Yeah, and that's where things like the Workforce Summit could add value, because you're attracting people in, they recognise the value of providing services here, they want to work in partnership. So I think we could use those sort of forums to encourage people to work differently beyond treatment as well.
Councillor Andre.
Thank you, Chair. Yes, I just thought it might be helpful. Public health was mentioned here, and of course, this is a space that public health very much work with the ICB. The approach for, currently for public health is to embed oral health prevention initiatives within wider health and social interventions, but there are particular services, for example, through maternity services, through public health. There's the encouragement to take up the entitlement to free access to NHS dental services where they exist, but also to educate both for the mothers and to prepare for the children. Our public health nursing team cover 0 to 19. We've got our PEACH programme, which is public health working through education, where settings in all phases of education can access free e-learning for staff on a variety of topics, including oral health. So there are, and also, of course, our holiday activity and food schemes do actually have within them, it's embedded about health, which also includes dental health of children. So there are things woven through the public health agenda, but we do work closely with the ICB through to get that message out. Thank you.
Thank you, Councillor Andre. I believe Simon's popped up, so he probably has something to say.
Just support Councillor Andre's statement there. Absolutely. We're working very closely with ICB on really focusing on those communities, particularly through our health visiting service to promote oral health for young children. I know Joe mentioned, weaning and things like that. They're all part of the service and actually a real rich tapestry of kind of dental health work, which isn't just about dentistry.
Thank you, Simon. Do we have any other questions? Yep, Councillor Nicholson, and then
Following on from Councillor Spink, going to ask James, would it be helpful for this committee to pass a resolution to ask our MPs for progress on what's happening with the government to review and reform dental contracts as soon as possible with an urgency to develop a contract that is attractive and workable to dentists, particularly in coastal communities like the Isle of Wight that are currently being severely disadvantaged?
Yeah, I think it would be helpful, but just to reiterate, when I make the point about the MPs, I was reflecting their willingness to support us with this issue, but I think you're right to ask for progress on our behalf, and clearly we engage with MPs as well, and we'll ask the same question. And I think now is the right time.
So I propose that. That's a resolution seconded by Peter.
those in favour? Passed. So
Perhaps we could combine that with asking them to report back to us in writing at our next meeting, which I think is that going to be in January now?
March.
That gives them plenty of time, even
Yeah.
by MP standards.
So in summary, the committee will write to both MPs, express to them that we would like to see a change nationally in the contract, and we would like them to lobby the government for that, and also to ask them to report back to us on what they have been doing and what they intend to do as well by March. And I think that will be particularly relevant for our MP Joe Robertson, as he sits on the Select Committee for Health now, so it will be interesting to hear from him. Councillor Jarman.
Thank you, Chair. It's very gratifying to have the comments from James here, and also to hear the name of Freshwater being mentioned quite so many times in one council meeting. We often get forgotten somewhat on the western tip of the island. And I applaud the committee for the resolution that's just, the motion that's just been passed there. We, as a community, recognise prevention is better than cure. We understand the logistics. We understand the financial aspects which are involved in it, which Councillor Drew has very adequately explained. The issue that we've also been progressing at the same time is about meeting some of the need for additional dentists. In particular, this isn't only a freshwater issue, it's an island issue. We have identified an opportunity in conjunction with our Ukrainian colleagues to bring Ukrainian dentists to the island. We've discussed this with the ICB. James is very familiar with it. We discussed it with Denby House, who are very supportive of it as well. In particular, a wonderful Ed Day, and I can't praise him enough for the work that he's been doing with us on this. In order to progress that, we have a challenge, and the challenge is that the Ukrainian regulatory body and the professional qualifications for dentists are not yet recognised in the UK. So although we can bring them here under the Homes for Ukraine, they cannot work as dentists. The program to get them to be able to work as dentists requires an English language examination and a Part 1 and a Part 2 examination for dentistry in London or Manchester, which takes a very long period of time, up to 2.5 years or so. So we have written as a community, and myself in particular, 4 times now to our MPs, asking them to engage with us so that they can lobby the respective ministers to add the worldwide renowned Ukrainian dentistry qualifications to the list which is recognised in the UK. I'm disappointed to say that we've not received a single response to those 4 requests for engagement, similar to Councillor Spink's note that he's also written twice on other topics and not received a response. So I wonder if I could now seek the support of this committee, whilst getting those details from our MPs, if they would please engage with us in our community on this specific topic, where there is a real and imminent opportunity to bring additional resource, and perhaps in bringing them to ensure that they are NHS only practicing dentists. And wouldn't that be a wonderful thing? Thank you.
Thank you, Councillor Jarman. Perhaps we include that in our, when we write to the MPs. Can I take a proposer for that? Yep, and a seconder, and all those in favour? Lovely. Okay, we'll include that when we write to the MPs. Thank you, Councillor.
Thank you, Chair.
I had a question for you, James, on the topic of recruitment. I was wondering, I take it you get regular feedback from the providers both on the island and also in Hampshire. Comparing the feedback on recruitment, I'm sure it's hard for all dentists. Is there anything particular about the Isle of Wight that makes it more challenging than other areas?
I think there's the issue, in terms of accessibility. So it is difficult for people, I think, to sort of commute from the mainland and work a full day and get back, and the costs associated with that. So the main feedback we've had is those that have worked for a bit and gone back to the mainland, is they've absolutely enjoyed the work here, the clinical variety, the opportunity it brings, but it becomes unaffordable either for them or the practice. And that was pre the days of golden hellos, and we are supporting with travel as well. So I do think that sort of thing has put them off. The UDA rate as well obviously affects how much the dentist gets paid. So I think we are making progress now, where I hope we would attract more dentists to work on the island and newer entrants as well. So once the academy is established, then we should find a more natural flow of dentists. But I think for lots of them, it's nothing to do with the area or the dentist they're working in. I think it's the logistics and the practical challenges of travel and the costs associated with it.
Thank you. So that sort of suggests that those dentists perhaps can't imagine they don't want to live on the island, perhaps. So that's not or something that is attractive to them. Is that the feedback that you get, that they prefer to live on the mainland?
I think they currently already live on the mainland, so a lot of them are seeing opportunities to work on the island at a particular rate. I think the NHS dentists we have who live and work on the island are of a very high quality, and they're very committed. I think ultimately, longer term, we want more of those type of dentists, if you like, that are here for the sort of the long term. But I think with the initiatives around more activity, higher UDA rate, golden hello, support with training, that's creating the right environment as well. So hopefully that will help.
Thank you. Thank you very much. Does anyone have any other questions for James on this topic? Thank you. Thank you very much for bringing this to us. The report was really interesting, and the discussion I found really useful as well. And I look forward to seeing the strategy in the new year. Thank you. Okay, we're now going to move on to the Isle of Wight and Portsmouth NHS Acute Services Partnership. I'd like to say a huge thank you to Penny for coming to our informal. I found that very, very useful, and it was an interesting discussion. So I'll hand over to you now to give a summary. Thank you very much.
Thank you. And if I might just introduce my colleagues as well, I've got Dr. John Knighton, who's our Chief Medical Officer, and Michelle Stanley, who's our Director of Strategy and Improvement as well. So we've just drawn some summary slides together just to extract from the main document, but I'm going to take the document as read, and I hope you'll see that gives you a pretty comprehensive history of the partnership since 2019, and in particular since we became an NHS group in June 23. So I just wanted to pull out 5 things. Thanks, Michelle. 5 things that I think have changed since that point, and
why we're doing those things. And then John's going to talk about, in particular, the clinical strategy and the clinical model, because that's where the change starts to actually happen. But a few things just to draw to your attention, because I think it's really important to acknowledge that in 2019 there was a recognition from the Isle of Wight Trust that those partnerships were very important for us to be able to sustain access to services on the island. But that doesn't mean that everything that we're doing is together with Portsmouth and the Isle of Wight, or indeed with other partners. And so one of the very significant things that we have done since that point is publish the Isle of Wight Trust Strategy. And that is a trust strategy that describes what we are here to do as an acute and ambulance provider. And importantly, what we will do to meet the needs of this population. And that strategy describes the very particular needs of this population, but it also describes what we will do in partnership with others. And I think the really key bits of partnership with others are, of course, the group with Portsmouth, and what we've shared in the paper and what you can see running through that slide are the 6 imperatives as we describe them, which are the joint pieces of work that we're doing between Portsmouth and the Isle of Wight to make sure that we've got a single approach for the 2 organisations and the 2 populations that we serve. One of the key ones we'll come back to, which is the clinical model. The other piece, though, to notice that has changed, of course, is the transfer of the community mental health services to the now formed Hampshire and Isle of Wight Healthcare NHS Foundation Trust. But what you will see in our trust strategy is a recognition of how we want to lead for the island in terms of the coordination of those health services in particular, so that a change in organisational form is not impacting on what our patients can expect in terms of access. And then the 2 other changes, which John will come and describe in a bit more detail, are the clinical strategy, which is relevant certainly for both the Isle of Wight and Portsmouth, but I hope you will see is entirely consistent with the Hampshire and Isle of Wight direction of travel, and consistent with those strategic transformation programmes across Hampshire and Isle of Wight. So they are principles of care that we would expect to see translated into plans, certainly in our 2 organisations, but I think you would expect to see them across Hampshire and Isle of Wight, so that we are making sure we're meeting the needs of the population. And then the key one is, so how are we translating that into the clinical model, so that we have genuinely got to a point where we've got a single service that is serving both Portsmouth, South East Hampshire and the Isle of Wight. And there are some examples of where we've already made progress with that. John will describe the approach that we're taking, but just to reinforce, I think actually some of the points that we've heard from the earlier conversation is this is centred around making sure we're meeting the needs of our patients, but it is so that we can access reliable, resilient services for the Isle of Wight population that's delivered through a workforce model that is not as reliant on temporary workforce as we currently are, and certainly not as reliant on single-handed practitioners as we currently are, which is where the kind of vision for that single service across both hospital sites serving both populations comes from. And it was one of the rationale behind the partnerships to make sure that we had that resilience of partnerships, certainly with mainland providers. I think the other benefit that we are hoping to achieve is that benefit of consistency in terms of standards and expectations wherever, whichever population we're talking about. So the paper also talks about what we've done to bring together our support services for our clinical services to make sure that whether you're in Portsmouth or on the Isle of Wight, actually there's a common approach to how we're planning our services and how we're supporting those services through the single corporate services, which you might have heard about as well. So I hope that is a summary of that slide, and that slide brings together quite a lot of the paper. If we move on, John will describe the principles of the clinical strategy and then the clinical model, which is one of the 6 key imperatives.
Thank you, Penny. So yes, if I may, there are two separate but closely related pieces of work that I'm going to refer to. One is the clinical strategy. So that is a clinical strategy that we see being fit for at least the next 5 years for both organisations, for the island and for Portsmouth, and developed with both organisations. And it is, at its heart, it is a core set of principles that are looking to the way we need to change healthcare to meet the needs of patients in the future, and prioritising the things that we know clinical staff, operational staff, managerial staff, and patients value most highly. And it recognises the fact that we can't just keep doing more of everything in the same way, using the same models as we have been doing, and that in trying to do that, we are our capacity and capability to meet patients' needs is failing to meet them in the same sort of volume. We have to think differently. We see the demand on every front going up, and we see patients' presentations and patients' needs changing. It's increasingly rare for patients across the country to present with a single organ or single system illness. As you look at older populations of patients and communities, particularly coastal communities, and of course this is particularly the case on the island, the majority of patients now present with more than one condition and live often with multiple conditions for a significant part of their life. And yet the model for the way in which we meet healthcare needs is still often very historically focused, or focused on a historical model of a single organ system. And so patients suffer that being passed from one service to another without the holistic connection of meeting need in the way it should be. So would you just move the slide on for me, Michelle? Thank you. So I will be brief about this, but very happy to take questions. But there are a set of core principles, and these have been worked through in a widespread, a relatively lengthy period of consultation, which started in Portsmouth, but then as our partnership developed, we brought into the island context as well, and checked and come up with exactly the same conclusions as to the things that are of most value. And I'll start with just one or two, because I think they are worth calling out. The valuing of patient experience as much as a quantified outcome is something that, perhaps not surprisingly, rings true in every community. The thing that might need a little bit of discussion and potentially something that I think we're keen to engage with communities in a more proactive way as well is the concept of realistic medicine and shared decision making. Ones where the concept being that we much more thoroughly engage with patients about the choices that they have when undertaking healthcare, the options to have things done differently, and the options explicitly to choose not to have an intervention, a procedure, or a treatment started. We know that when we do that, something like 10 to 20% of people, depending on what the procedure or treatment is, actually do choose not to have that intervention, and they report a better experience as a result of that. Conversely, we know that when many patients, for example, have an operation, the outcomes that they report are significantly less valued than the one they thought they were going to get, because we haven't necessarily engaged in as detailed a way as we could do with patients. I think the other thing that we recognise, particularly in both populations, actually on the island and in Portsmouth, is that with an ageing population, we know that we know that end of life care rarely meets the need of patients in the way you would like it to. We also know that patients, communities, citizens mostly would like a conversation about the end of their life and would like to be able to express choices, and would like us to then be able to meet those in a way that is often different to the way we end up meeting them, which sadly far too often results in a conveyance to a hospital and a poor experience at that very end of life, which could be done better with conversations earlier and resource directed in a different way and earlier in patients' presentation. There are other things there which perhaps we can come back to in questions, but I would just highlight that last point on the slide, number 7, aligning service delivery to meet patient need, because that does sound a little bit jargonistic, but that really is what I was talking about in terms of patients presenting with more than one condition and often with chronic conditions. and the fact that we need to align the way we think about service delivery to those needs, the length of them, the longevity of them, and the multiplicity of them, rather than just thinking about treating a kidney problem, treating a heart problem, treating a lung problem with a series of different multidisciplinary teams. So that's the clinical strategy, and these principles are the ones that we are asking and will be increasingly incorporating in all of our service planning and design for the future on the island, and actually just as much in Portsmouth as well. But the other piece of work is really very focused on the island and the sustainability of the acute services provided by the hospital on the Isle of Wight. And this is what we call the clinical model. And this has been developed over the course of last winter through a series of several months worth of widespread engagement. And that's included large numbers of clinical staff within the St Mary's Hospital, large numbers of non-clinical staff, and with some patient groups as well. And this is looking at how we can describe an acute hospital that can meet the needs of patients in a way that is, as Penny's already referred to, and I suspect everyone recognises, not dependent on temporary workforce whose motivation may be absolutely right, but occasionally won't necessarily be committed for the long term, won't necessarily be able or also interested in developing the service to champion innovation in the way that perhaps can be done through a larger network or a larger organisation. And to be honest, has been a big part of the driver for Portsmouth and the island working together in partnership. In fact, that is, in essence, that is what it stems from. So we've worked through what that should actually mean and what it could look like. And this rather simplified diagram, I think, does help to explain the concept, which is that at the core, in the purple bit there are some services that can and will always need to be provided by an acute hospital on site 24/7. So they are largely the emergency services, the emergency department, maternity unit, paediatrics, and the ability to admit and treat the generality of what we divide as medicine and surgery, but underneath that sit a whole range of other presentations. To be able to do that and deal with all of the acuity of patients' presentations in that group, we need the capability of an ambulance service and a critical care service to both stabilise and manage those patients on the island where that's appropriate, or for those patients who need a specialist or a high acuity intervention that can only be provided on the mainland, as currently happens, we need that transfer to be able to be enabled as quickly and as safely as possible. But there is a different model around specialist services, and rather than trying to support, and I won't use any particular examples, but happy to take some up in conversation. Rather than trying to support subscale models for specialty service delivery in a way that is a challenge to recruit and retain staff, and often a challenge to maintain either the quality or the capability to do interventions that will acutely impact outcome for patients. What we're looking at is a model across the two hospitals, across Portsmouth and the island, for a single service serving both populations. And that last phrase is the important one, and that's the one that we're now taking through already a series of workshops that we've started through this first series of specialties, which, as I say, is a single service serving both populations, serving the island's population just as much as it serves Portsmouth's population. That will provide a different model for each service, dependent on the nature of the service and the scale and numbers involved within those services. But it is very focused on delivering or describing, in its first instance, describing a service model for that specialty. Let's say, for example, cardiology, that can meet all the needs of patients wherever they are, on the island or in Portsmouth, but as one team in that service. And that's so that's now a program of work that we have started on, having described the clinical model, been through the check and challenge process to confirm, I think, with a reasonably high degree of confidence from across both organisations and particularly clinical groups that is the right model. We're now starting to work through those specialty models one by one in a program of work that started a few weeks ago. There will, as highlighted in the diagram, be some enabling themes that cross-cutting themes really that will go across each of those different areas that we need to make sure we work on and develop. And some of these will particularly be relevant for the sustainability of the core on-island 24/7 emergency care model. And those particularly relate to the development of workforce models that are not just wedded to the traditional ones, but incorporate staff working to the top of their license in a range of different professions, working as a multidisciplinary team, focused more on the patient need than traditional boundaries, but obviously with the appropriate governance around the way they do that. And a key part of that, the ability to work across sites, of course, is that digitally enabled support. And that's something that we're putting a lot of effort into. And you will have seen that in the first slide, that what we call the blue slide around those imperatives. So that's probably the point at which I should stop, and then obviously very happy to take any questions.
Thank you very much, you both, for presenting that. Do I have any questions from the committee? Yep, Councillor Drew.
Thank you. In terms of one of those areas you highlighted in, I think, sort of realistic medicine, I wonder if you could perhaps explain a little bit more about what that entails. I assume it's essentially making a choice that is going to be in the best interest of the patient, not necessarily down a particular pathway, but perhaps the choice of not receiving treatment. Is that correct, in my understanding?
So that is, thank you. Yes, thank you for the question. That is absolutely one of the key tenets of realistic medicine. The concept of realistic medicine, if anyone wanted to look it up, and if in fact if you Google it, you'll see NHS Scotland have been working on this concept for about 15 years now. I would suggest they're way ahead of us in England, but they have very strategically identified an opportunity to put patients better at the centre of their care, and it genuinely is that through better better information for patients and more direct involvement of patients in their choices, including that the understanding and the option to have a different, less invasive treatment or sometimes no treatment, people are more satisfied with their care.
Thank you. Just following on, I mean, I think it's an approach that, I mean, certainly from my own perspective, my father, who I hope won't mind me invoking his name in terms of prostate cancer, was given that sort of option of watchful waiting and took it. But I think from his perspective, it did require, on my part, a little bit of elucidation as to what exactly that entailed and to sort of follow up. And I think that certainly on the Isle of Wight, there are perhaps some people who don't necessarily have an advocate or someone who can explain. And, you know, you speak of consent, and I think the question of informed consent is something which, I mean, obviously in all areas is going to be a concern. But I think on the Isle of Wight, there is a dearth of, you know, third-party organisations who might be able to act as an advocate and such. So I just wondered, you know, to what extent on the island that could be addressed in terms of making sure there are, you know, patient liaison volunteers or, you know, those who can sit down, spend the time and really ensure that patients understand what it is in terms of options open to them.
Thank you again. I think it's a really good point, and I'm sure there are more things that we can do. I think, though, I would take it back even a stage further with the concepts of realistic medicine and shared decision making with patients, which is that I think we need to engage with communities before they become patients, with citizens, about the rights and to an extent the responsibilities that we all have for our own choices in healthcare. And I think the more we start doing that on the island, just as much as anywhere else, perhaps even more so, given some of the challenges with an ageing population with multiple morbidity, I think the better we can help patients choose wisely and understand the choices that they're making.
Just if I may, through the chair, in terms of when a patient is admitted and sort of the information that they're given in terms of, you know, where they can seek further data, further sort of help and support, is there anything by way, sort of sounds a little bit trivial, but in like a welcome pack, as it were, so that they have that hierarchy of who's going to be their case manager, who's going to be, you know, where would be the next port of call if they have inquiries and queries?
Again, it's a really good question. So there is some of that, but I would say it's not at the level that you're really asking about. And one of the other principles that we've included as an enabling theme in the clinical strategy is recognizing exactly that. So I would cite the example of where it's done well, which is in cancer care on the whole, where the concept of cancer care navigators, and they've that role fulfilled by a number of different professions in different areas, but that person is a key coordinator and navigator for the patient as the patient's advocate, but also as the person who really understands those services. That's something that doesn't really exist very much in other areas of health, and yet it's I believe it's an absolutely transferable model, and one that not only could improve patient experience, it could cut down waste of time, patients' time, and probably healthcare providers' time as well, and almost certainly cut down the waste of resources. So that's absolutely why we've embedded that within the clinical strategy, and something that we're looking to take forward in both organisations. Thank you.
Thank you. I'll come on to you quickly. I just had a point off the back of that, and then I'll go to Councillor Spink. I find that very interesting. We recently had an informal on the Hampshire and Isle of Wight mental health community, the trust. Sorry, forgive me. It's lots of long names, and that was a topic that came up in that discussion, particularly around helping people to navigate services. Even when it's multiple different things, multiple different practitioners they need to talk to. And one question I raised at that point was for particular types of patients, perhaps those who've experienced trauma, perhaps domestic abuse and sexual assault survivors, might find certain services difficult to access. And so certainly that seems applicable for those type of people, is to have a navigator or someone that can help them to understand what is the treatment that is going to be done to them and with them. But I know that the concept of trauma-informed care is something that a lot of people prescribe to, and I presume the Trust does as well. But that's all I want to say. Thank you. Councillor Spink.
Thank you, Chair. I just really have an observation and a request really for the future. And that is, when I read this report, it seemed quite high level, as it were, not a lot of detail. And then when I looked back, I saw that this partnership was only formed in 2023, and therefore that's why the report is high level, because exactly what the changes are going to be haven't yet been, as I understand it, determined. But could I put in a general, it's not a criticism, but just a general comment, and that is this: when they are determined and you report back, could we deal with the nuts and bolts of it rather than high level sort of aspirations? For example, I mean, it's just me, I think, getting grumpy as I get older, but probably can't find it now, which serves me right. But I find some of the expressions in here, I have to read 3-4 times to actually understand what's being said. And so I just would put in a plea, please, for reports that are a little more down to earth, deal with the nuts and bolts, and are in plain English. I think all councillors in all areas would find that helpful, and I'm not singling you out in any way at all by way of criticism. And I do understand why this report had to be extremely high level, but I did feel by the time I got to the end of the report that whilst having lots of good aspirations, I didn't really know what was going to be done. And that's probably, frankly, because no one knows yet until it's agreed. Thank you.
Thank you. I'm happy to respond to that and absolutely take that on board. And I think what we were trying to do was to strike the balance between making sure that you were well cited on the context and the things that might change in advance of there being any formal proposals. And I do think, and partly that came out of the informal conversation about building the understanding of, are there going to be significant things that impact on patients, or is this about the way that we ensure that we do sustain the services that we have? So yes, when there are specific changes, if there are specific changes, those will be the next pieces that come forward. But this context was hopefully important to set the ground then for those conversations.
Yes.
Generally on the same sort of theme. It's an overall, it's a good report and quite informative. But, and I made this comment about this report, but in fact it applies to so many reports we see here. I go to page 29 and there you've got your 6 objectives. 1, 5 and 6 are general. Fine, they're going to evolve over time. But 2, 3 and 4 are very specific. I think when we have a specific objective, there ought to be a time factor built into the document so that when you come back here in 2 years' time, we can say, oh, did you achieve that last year? So again, use of specific objectives where they're not sort of nebulous, like work around the systems with Portsmouth and South, blah, 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 you know, all those sorts of general ones, but where it's much more saying, create a single corporate service, create digital and data systems. They are specifics and there should be a time factor involved. I say this not just applies to this, but I read so many reports where that factor is not taken into account. So in a sense, you can't scrutinise when you come back whether in fact you've done your job.
Yeah.
Sorry about that.
No, fair point. Thank you. So underneath each of those 6, there are very clear delivery plans. And even for those that might appear less specific or at least more ongoing into the next financial year, there are absolute milestones for the end of this financial year. And for those that will be near complete by the end of this financial year, milestones nearer term. So the corporate services, for example, since the 1st of November, we have been operating as a single corporate service across Portsmouth and the Isle of Wight. So that one you could say is complete insofar as that's a box tick. The ongoing work then is the development of those corporate services to make sure that they do support both of the organisations. So yeah, well, we can make sure that that detail that does exist is lifted out into some of these reports.
Thank you. Yeah, Councillor Jarman.
Thank you, Chair. Just a simple question, but perhaps it might require a more difficult answer. When will the technology platforms between doctors, other healthcare providers, other NHS resources and hospitals connect and work?
You're right. It's a very straightforward question that we would all hope there was a straightforward answer to. I can't give you a date, unfortunately, for that. And it's an example of where that digital imperative is one that is ongoing. There are some milestones within it, such as the work to progress a single electronic patient record at an acute services level across Hampshire and Isle of Wight. We haven't yet cracked the full integration around a patient journey, so all health services. We do have access to some of that services, so I'm sure you've heard about CHI and the spine, which we have access to, but a fully integrated patient record, I don't have a milestone date to be able to share with you, unfortunately.
Yeah, I mean, it is a really important question, isn't it? And it is a long way yet from where we would like it to be as clinicians and from where as a patient you want it to be, of course, which is continuity in both of those senses. In addition to what Penny said, though, no one is waiting for the definitive single solution. So there are numerous pieces of work. So if you look, for example, at interoperability or patients who are on the island who might need some of their treatment in Portsmouth or being seen and treated by some clinicians in Portsmouth. So we have now enabled some steps that really were very difficult only a short while ago for clinicians being able to see records across each site. If you look out into the communities, the NHS app actually as a national piece of work is becoming far more capable than it was even 2 years ago, and more of the platforms that each organisation or healthcare area, be that primary care or secondary care, had previously kept within its little world, are now being transferred and accessible onto the NHS app. So there are lots of things that are ongoing, but it is still a long way from where it needs to be, because we genuinely do need a digitally enabled healthcare system, and a system, not a series of disconnected systems.
Just a follow-up on that, perhaps an equally simple question. I'm full of simple questions today. There are parts of the NHS which don't seem to be visible within the app at all at the moment, dentistry being one of them, for example. Is the plan to maintain the NHS app as a single point of patient view, and will the other elements of public health care be integrated with it?
So I'll have a go, but you'll forgive me, because I'm not the right person, and we're not the right people to be able to give a meaningful answer. But I believe the direction of travel is towards developing the NHS app towards accommodating most of that patient interface. Yes, and that's certainly been the direction of travel over the last year, and it's certainly what I've heard discussed increasingly, is that there will be more taken onto that platform from a patient perspective. Yes.
I'll just bring Laura in.
I'd like, if I may, to revert to the previous question around a single health and social care record held digitally for all citizens in the United Kingdom. I was particularly fortunate on Friday to attend a private session with Sally Warren. Sally Warren is the Director General who's been charged with leading the joint Department of Health and Social Care and NHS England team to develop the 10-year health plan. As part of our discussion, she asked me what my one wish would be. I don't know how seriously she takes my wishes here on the Isle of Wight, but I viewed it as a very serious question and gave her a very serious answer. For me, that is the development of a single health and care record. And our government is uniquely placed to be able to support us to do that by providing the tool. We talk about it, but actually the trust has one set of procurement rules, the local authority has another, GP surgery a third, dentist a fourth. To make all of that tie up and to comply with our own legal duties around procurement is particularly challenging. I know we're soon to be going out to tender for a new social care record. The likelihood of me ending up with the same as my health partners on the island is a likelihood I wouldn't even begin to guess at, because it's an open, transparent and competitive process. The person who wins our business will do so on the basis of the evaluation criteria we set out. If our government was to put in place a tool that we could all use, that would alleviate and completely remove that obstacle. So it is something they are thinking about as part of the 10-year plan development, and I just thought that might be helpful to relay.
Thank you, Laura. Just from my own very small, tiny micro version of trying to get data systems to connect through our till system and our web system and our ordering system, incredibly, massively difficult. So I can only imagine what the challenge is for a system as wide as this. Councillor Jarman and then Councillor Drew.
Yeah, so I'll give you a practical example. We spoke a lot about dentistry and freshwater earlier. Let's use the word freshwater name a few more times, why not? One of the issues we've read in the paper is that patients no longer are on a list with an individual dentist. They can effectively go to any dentist they want. You're not registered with a specific dentist, and it's up to the individual dentist whether they will treat you or not. So we understand the nature of the system. The problem is that my dental records are not universally available to any dentist I might go to. So that's one issue. If I'm part the way through a treatment somewhere and that dentist, let's call them my dentist in Freshwater, no longer exists and I want to go to another dentist, the other dentist is unaware of what has been going on with that course of treatment. That's the second issue that comes up. The third one is when a dentist shuts down, let's call them my dentist in Freshwater, the process for getting those dental records transferred to another dentist seems to be an inordinately complex system. I understand Data Protection Act. I've dealt with it in many guises. So the system here is the records end up being uploaded to an NHS system. There is then an ongoing process, which we haven't cracked yet, to get them morphed in some way, to get the data accessible in a different way, and to get that data provided to the new incumbent of that dental practice. Again, these are all encumbrances which, you know, when I look at them, I don't understand why it is still an issue in the world. And for the patients, it's a nuisance. For the dentists, it could be a matter of life and death. If critical transfer is not made of allergies and reactions that people have, then mistakes can ensue. So this isn't an issue which is a trivial issue. It's, for I think for many people, a very serious issue, and it does need to be addressed. And I think the example of dentistry is a good one because it's not yet on the NHS app. It's not integrated. Different dentists have different platforms, and there's no single point of view either for the dentist or the patient.
Joe.
Sorry, yeah, I totally agree. And from the point of view of dental providers, I think they're the only health service that don't have access to people's medical records. So they are totally reliant on what people tell them. And if people are on a lot of medication, sometimes it's difficult for them to remember what they're on, which is very risky for dental providers. And I know that the ICB were doing a pilot on the island where they were supporting a dental provider to access health records. And it might be useful to get an update on that at a future meeting.
Thank you, Joe.
Follow, if I may, Chair. So the example I gave is not only a serious one. The response to it, because of the delays within the NHS processing system, is that the freshwater practice are now starting the process of rekeying nearly 4,000 patient data records one by one.
I will move on from this just because it's probably more relevant for the ICB who've been longer here. But I will note that and
Thank you, Chair. I don't know if it does strictly come within the aegis of this report, but in terms of the ever closer union, as it were, between Ireland and mainland health provision, in relation to patient transport, I was just wondering whether you might be able to summarise what the current status is and if there are any particular, as it were, pinch points more and above, you know, what we experience as islanders with the two ferry providers. Because I think, you know, clearly one of the roles we might have, given that so many councillors are keen to see the regulation of the ferry providers as to what we can do in terms of advocacy to them. So I don't know if anyone would be able to speak to that, what the, you know, how amenable things have been, if there are any pinch points on what we can do as a committee to advocate that further.
I'll happily have a start. So thank you again for the question and for I think the suggestion, because in the partnership between the island and Portsmouth, we're really keen to make sure that one of the principles is that we don't ask patients to travel unless it's, you know, in their interests and really the right thing to do. So the first thing is we want to minimise, not increase necessarily the number of patient journeys across the Solent. We are, however, having more staff that are travelling to support some of those models, and that will continue to be the case, and probably significantly more so over time as we look at how we can develop sustainable models. So we've seen, I think, in terms of the development of island services, and particularly at the most sharp end, so when patients need to transfer urgently, we have seen some really innovative work done by the ambulance service on the island, working with ferry providers, but actually with, for example, the hovercraft, to be brought into that capability in a way that it historically hadn't been, and was therefore dependent on, for those most urgent transfers, helicopters, which actually often can't fly in the conditions that even the hovercraft may be able to operate. So there's a lot of work already been done, I think. But I do think your question is absolutely right to pose, which is what can the island community and perhaps this committee do with the transport providers to enable the model, be that for patients or for staff travelling across the water to support those models. So thank you.
I just had a point as you brought up hover travel. We had a really interesting informal meeting with Neil Chapman, who's the chief exec of managing director of hover travel, and he brought up the patient transport, which he thinks has been working really well. The other thing that he brought up that was quite interesting was about staff transportation. So he mentioned that there has been occasions where he's noticed that there are multiple staff members all going to the hospital that come across on hover travel, and they're booked on the most expensive single tickets. And he expressed that he would really love to have a conversation with the NHS Trust about reducing that cost and coming to some sort of deal. So just to give a heads up that he would be open to that conversation.
Well, thank you. That's excellent. Because you're absolutely right. The hovercraft on some days at particular times in the morning and in the evening is full of NHS staff. You're absolutely right. Thank you.
I had did anyone else have any other questions before I asked some of the ones that I had on my list? No? Okay. So just on the topic of data, to go back to what we had spoken about earlier about accessibility, is the issue of accessibility come into that topic on the strategy around digital systems? And I believe we had an email from you before, Penny, in October, I think, where you mentioned that you were bringing together a gap analysis about that. And I was wondering if you have any, it was only very recently, but if you've got any progress on that, I'd be interested to hear.
Thank you. So you're absolutely right. It does in part relate to the challenges that we have with the digital systems. It's not as straightforward as any of us would like it to be. So our patient administration system is quite out of date, and therefore the letters that are generated from that is not as straightforward to change the font size as we would like. And you reference some particular specialties which will be on different systems that makes that more difficult than we would like. I haven't got an update against the gap analysis that was being done, because that was to be able to give you some more confidence about where can we do that, which services are we able to do that, and therefore where patients raise concerns that it's not happening, actually there should be a straightforward fix, and which are those areas where it's more challenging to do that. If we make some of the progress that John's described in terms of use of the NHS app, then we'd be able to do some of the things that Laura's described we're able to do in social care, and actually we'll have electronic access, recognising that we will still have challenges in access because not everybody will be able to access things digitally. So I think probably we need to bring you an update once we've concluded that gap analysis.
That would be great. Yes, please. I'd be interested to see that. And the other question I believe I had, so for us as counsellors, we probably would like to be able to go back to our residents and give a very concrete, easy to understand example of the ways in which the partnership is making progress and is making their care better for them. And I was wondering if you have any examples, whether that's a small example or a big example, of how the partnership has delivered that so far.
Thank you. I can give a couple actually, some of which were in development before the formal arrangement of the two organisations as a group in 2023, but have been taken further. So the first one I would talk about is cardiology, where the combination of the island's own cardiology team worked very closely with the hospital in Portsmouth's cardiology team in a service where there are a large number of patients with some sort of need, and also with a small number of patients with a very high acuity need to be assessed and treated and transferred for an intervention that is genuinely life-saving and outcome defining. So our cardiologists on the island undertake procedures in Portsmouth. Our cardiologists from Portsmouth visit the island and see and assess and treat patients there, and they have a pathway for transfer of patients that starts with the ambulance team recognising that need for an intervention and effectively a fast track using whichever form of transport is available. It has traditionally been helicopter, but it has also been the hovercraft to get them to an emergency procedure, cardiac procedure in the intervention suite in Portsmouth. That model is already delivering, I think, the benefit for patients. What it needs to do to be sustainable for the future is to have some of the work that we talked about earlier on in terms of workforce models that are not dependent on temporary workforce, or not just dependent on people just adding to something that they do in their normal job plan, but bringing in staff who are a part of a team that delivers that service as one service for both organisations.
Thank you very much. It's useful to have a concrete example. It helps to illustrate it to our residents, and it's good to hear that they see themselves as one team rather than separated by a bit of water, that they want to work together. That's all my questions that I've got. Councillor Jarman.
Sorry, I'll make this my last one, Chair. I've been attending quite a number of the online briefing sessions recently about the digital switchover. You're probably aware that the island is at the forefront of this, which is now imminent. In fact, some parts of it already started. It's already thrown up a number of anomalies. For example, analog telephones connected to defibrillator boxes, etc. Can you assure us that all of the NHS services on the Isle of the Wight are digital switchover ready?
So I wouldn't want to give you complete assurance because I haven't seen something that's done that analysis, but we can certainly take that away and ask that question to give that assurance back.
Thank you.
Thank you, Chris. Are there any other questions? No? Okay. Thank you. Massive thank you for coming and for delivering that. And I look forward to hearing some more updates next year from you both. Thank you. Thanks. Thank you, Chris. Okay, we're going to move on to agenda point 8, poverty reduction strategy on pages 37 to 78. I believe I'm handing over to Councillor Andre to present. Is that correct?
Pardon me. Thank you, Chair. The poverty reduction strategy, I'd just like to say a couple of things before I hand over to Ian Lloyd. It's a whole island strategy. We accept that as a council, we need to recognise that the only way that we are going to reduce poverty is by working collaboratively with our partners, and to recognise the work that is currently being done on the island to help those people. We know we will never eradicate poverty, which is why it's a poverty reduction strategy, but to actually recognise the good work that is currently going on, but to also build on that. And I'm sure Ian will highlight the 3 pillars that we are promoting within the strategy. So without further ado, I will hand over to Ian. Thank you.
Thank you, Councillor Andre, and thank you, Chair. So just in summary, obviously there has been extensive work over the past year in forming this strategy. It's been no mean feat, to say the least. And it is based on lived experience. And I think that's the critical aspect of this strategy, to recognise some of those experiences that are being felt within the communities across the island. It is collaborative. It has been formed on the basis of the Isle of Wight Council as one partner, but collectively with other partners. Health colleagues were here earlier, the ICB, also with our voluntary community sector, and equally through some of our local town and parish councils as well. So it is a collaborative approach. It is recognising what some of those challenges are. I think it's also been very challenging in trying to articulate precisely what the aspirations are around this. But we have focused on 3 pillars, 3 primary priorities. First and foremost, recognising that there is a lot of work that continues to be undertaken around targeting support here and now. On a daily basis, there are residents within the community that require that support and access to that support. So it's about looking at what that is and what that can continue to be. Secondly, it's about looking at what we can do to prevent. So it's not just being reactive, it's about looking at prevention needs. What is within the island's gift to aid and support some of our residents to navigate and work to their limitations, but also what they can do to help themselves in terms of trying to prevent some of the challenges they have. And thirdly, and probably most importantly, it's about, if we recognise the here and now, the strategy is about a 5-year plan, and it's about looking at some of the longer term aspirations and needs. And that isn't in isolation, it is in partnership. And partnership is a key theme that comes out within the strategy. It is an island strategy. It's not an Isle of Wight Council strategy. This has been produced with partners, and it is therefore important that as partners, we take this forward. Now, clearly, the strategy is the vision, is the direction. The actual doing is what will now be worked up. It's about bringing the strategy to life. It's about planning how we target, how we support, and how we navigate around some of those challenges. So within the strategy, it talks about key themes. It also has reference to other strategies that are emerging and developing, growth and prosperity being one of those, housing strategy and the island planning strategy being 3 key documents which will have influence over the deliverables of the island's poverty reduction strategy. So I think in essence, this is about the here and now. The Health and Wellbeing Board have approved this. It is going to the Isle of Wight Council's Cabinet on the 12th of December, and the paper will be released shortly. And the critical thing is now about the partners of the island being behind this collectively, so that we can start to take this forward and devise the means and the ways of achieving what is required to be delivered. So I hope that helps.
Thank you very much. Do we have any questions from the committee? Councillor Spink.
Thank you, Chair. I think Mr. Lloyd, well, my glasses have just fallen apart, but still, I'll repair those later. I think, Mr. Lloyd, you've answered to some extent my question, which was going to be along the lines of my previous questions, really, that this strategy is quite a full strategy, but it is that it's rather high level. And will you be producing all of these are very good aspirations, if I may say so, but the nuts and bolts of how they're going to be achieved aren't really in this strategy. So do you have any time frame over as to when it is that, for example, action plans, rather than waiting for one very long action plan covering everything, so say, for example, the action plan on housing, say, for example, the action plan on children specifically being taken out of poverty to the extent that that's possible. Can you give us some guidance, please, on when some of these action plans and with a date for the actual action to be carried out by might be available to us? Thank you.
Chair, I wonder if I may step in or not and respond to that question. I'm the council exec with responsibility for the poverty reduction strategy. And firstly, I'd like to extend my thanks to Ian for doing what has been a particularly challenging job, trying to develop a policy that is on behalf of hundreds of local organisations from within this building is complicated at the best of times. I use the word complicated rather than complex because I do see a difference between the two. To ask Ian to develop the action plans to deliver on that strategy alone is something I'm not prepared to do. He has been the conductor of a very finely tuned but sometimes out of tune orchestra. And now it necessitates our partners stepping into that space to really support Ian and the rest of his team to deliver those action plans specific to those service areas. In relation to your question around housing, that is absolutely something within my gift as the Director of Adult Social Care and Housing. And that action plan will be developed within 3 months of the creation and the approval of the poverty reduction strategy, similarly for adult social care. I can't speak for other organisations or other parts of the local authority because they have their own time pressures and their own priorities. For us, housing is a priority. We know as a council it's something that's incredibly important to all of us, and that's why we've committed to delivering the action plan or the implementation plan to underpin the strategy in that area at such pace. What that means is it's likely to be a series of sprints rather than a marathon. We'll aim to pick off things as we go along to start really driving that improvement at a local level in bite-sized chunks. And I think I've used every single possible quote or phrase I could think of, but I do hope that that helps.
It does to some extent, thank you. Firstly, I wasn't in any way, I had hoped that I made that clear, being critical of the work that's been done so far, and certainly not being critical of Mr. Lloyd. As I say, I accept it's I entirely understand that it's a high level strategy at the moment. I suppose I'm just being a little impatient that it would be nice to see some actual nuts and bolts. Now, one of my views, which I've expressed quite strongly recently, is that an important aspect of taking people out of poverty is housing, and that's recognised on several pages of this report. Now, I'm sorry if it's a specific, but I think it is so important because it does seem to me that the current housing strategy, it's not easy, but the current to provide truly affordable homes. And that problem has been raised many times now at Planning Committee, of which I'm a member. The Planning Committee is asked really to grant permission for, say, 100 homes on the basis that 35 will be affordable. And actually, firstly, that's not a very large proportion, really. And secondly, although it's policy compliant, secondly, of those 35%, not many of them are actually island affordable. That's a real problem. Now, it does seem to me that the best chance of having island affordable properties is to start building on council-owned land. And I'm going to ask this committee, but I'd like to hear what you say, that in specifically it's proposed by way of delegated decision, presumably you're aware of that, this being the relevant officer, to dispose of about 22 council-owned development sites which are suitable for homes, and it's not proposed necessarily to dispose of those to anyone other than private developers. Now that, to my mind, will only replicate the problems that we've got. It won't take people in large scale off the housing register. And I feel very strongly that those sites should not be disposed of, particularly towards the end of this administration, shouldn't be sold off and therefore fetter the policies of a new administration, which will happen in May. And that those sites either should not be disposed of, or at this stage, or disposed of with a term that they be disposed of to registered providers and stroke or housing associations. And a term of the disposal is that the overwhelming majority of housing built will be affordable, will be socially rented homes, not all, but the overwhelming majority, socially rented homes that are affordable by those on the housing register. I mean, would you be in favour of that policy to help the island's housing crisis?
Chair, if I may, I'm not sure that this isn't going over ground that was dealt with by the Corporate Scrutiny Committee only a few weeks ago when the full housing discussion and debate took place. I am not the officer responsible for disposal of local authority land. The officer who was present at that meeting and did provide those responses. I don't feel I can add anything to that to support or not Councillor Spink's position in relation to housing locally. What I would do is draw this committee's attention to page 28 of the poverty reduction strategy, which outlines the next steps that are proposed in terms of the opportunities for development of affordable, secure homes for island residents. And I'd ask that that perhaps goes, or I'd suggest that that perhaps goes some way towards addressing the questions that Councillor Spink has raised, and will be the basis of the implementation plan for housing that will underpin this strategy's delivery.
Thank you, Laura. I agree. I think this is not your remit entirely, but thank you for pointing out page number 28. What I think might be a proposal, and that I would ask the committee to consider, is whether we as a committee write to the officer and the cabinet member responsible to take into consideration what we see here in the poverty strategy in their decision of disposal. Would that be something the committee would consider supporting? Can I take a proposer for that? Yep. And a seconder? Yep. And those in favour? Okay. So to clarify, we will write to the cabinet member and the director responsible on this topic and refer to the poverty strategy in that decision. Okay. Thank you.
Chair, if it assists, that's the Director of Corporate Services.
Director of Corporate Services, thank you very much. Has anyone got any comments on that? Yep, Chris.
Just a very quick one, really. I was going to pick up housing as well, but you've done that so well. Because that is one of the root causes of poverty, in, deprived areas, deprivation. But I just got to say, I was at a meeting last week at People Matters, and there I was told about situation regarding people with learning disabilities, many of whom now are only relying on food banks for all their needs. And the comments I got were, they seem to be deteriorating as individuals. Now that group is not specifically mentioned in this report, but I think it needs to be borne in mind that there are special needs in certain areas. Learning disability is one of them. Thank you.
I'll let you jump in a second. I just had a topic that's relevant to what Chris had said. Firstly, I just want to say that I'm overall really impressed with this strategy, and I think it's incredibly comprehensive. And what I really like is that there is a lot of input from residents and their own views, direct quotes from them, and page 12 is really interesting, looking at the bubbles that say what the key issues are to residents, and that I presume informed Councillor Spink's thoughts on housing, because here the rising price of rent and lack of affordable housing are two of the largest bubbles, alongside the rising price of utilities and the rising price of food. So it's clear that that is something that a lot of people have on their minds. There was just one thing that I'd noticed that I was a little bit disappointed to see that it's been omitted. It's not listed on the page, one second, page 8 is the list of people who might be affected by poverty. Or on page, scroll down to the bottom, page 34 on the list of those involved. And that's domestic abuse. I was surprised that domestic abuse didn't really feature in this strategy, and that Paragon or U-Trust are not listed here on the groups involved. To me, I feel that domestic abuse and poverty are so linked, and the evidence does show us that. So, for example, women living in the poorest of households are 3.5 times more likely to report experiencing domestic abuse, and those that leave abusive relationships are more likely to report that they don't have enough money to pay for essentials, and they also report that the cost of living crisis exacerbated their experience of domestic violence and limited their ability to leave. So I would have liked to have seen that in there, and if there is still time, I would like to recommend that that's something that is featured in the report.
Just to come back on that, Chair, you're right to point that out. And I think in hindsight, we were trying to cover it in an appropriate way. So I can confirm that it was part of the discussions and the feedback. And referring back to page 8, it did recognise that, particularly with women, domestic abuse, and that's not to say that men don't experience that either, but it was a change in family circumstance that was referenced within page 8. That was to try and capture it in a wider sense. But it was very much part of the discussions. It will continue to be part of the discussions, and having that representation from the voluntary community sector as well was really important in terms of that broad array of support needs within the community.
Thank you for that, and thank you for explaining. And I did note there was also a quote from an individual who said about their sister who had experienced domestic abuse, so it did feature there. But I think that in the sort of the recommendations going forward and what we should be striving to do, I think reducing domestic abuse should be part of that, and I think that would have an impact on poverty. So I think for myself and possibly others who have an interest in this area, they would like to see it explicitly mentioned. But overall, I think the strategy is fantastic. Yeah, thank you, Laura.
I wonder, Chair, given your comments, if perhaps we can seek to engage with the Domestic Abuse Partnership, the forum, and all of our partners there to have a session specifically with them around the strategy and ask what contribution they can make towards the action plans to make sure that those action plans pick up that cohort of vulnerable island residents right across all of the activity that's proposed moving forward. It may be a way of ensuring we continue to engage that potentially marginalised part of our community.
I think that's a fantastic idea, really fantastic, because there are elements of what access people leaving domestic abusive situations have to funds and how that might impact them and their children's lives. And like the quote in the document said about that person being on a housing waiting list and being away from their support networks as well. Thank you, I really appreciate that. Councillor Spink, and then Councillor Drew, and then Chris. Oh. Yeah, please. Thank you, Chris. Councillor Spink.
I just quickly, in light of one or two things that have been said, in particular that an action plan depends on other stakeholders' contribution. So I've just seen, because it's an urgent situation, and I'm sure island residents would like to feel that something that could be done now is being done. And I mean, one thing, for example, that occurs to me is that we have, in the report, it says 34.2% of island children are in poverty. But in another part of the report, it says that 25% of children are eligible for free school meals. So we need to change that. And that, I mean, we need to change the eligibility. If we've got 34.2% in poverty and only 25% meet the criteria for free school meals, then something needs to be done about that. And that's something that could be done presumably, I don't know what the criteria is, but presumably by the council just changing the criteria. And the other couple of questions that I had, following on from that, page 21, increase the number of children taking up their free school meals, whereas somewhere else in the report it says we don't know how many children there are taking up the free school meals. So, I mean, these are like administrative defects, are they not, that we could remedy fairly quickly. I'll just finish on this general point, if I may. Let me just check if there's anything else before you answer. Again, provide free school travel to, this is page 24, free school travel to families affected by the cost of travel due to homelessness and distance from school. Well, we have a set, I sit on the appeals committee, we have a set of free travel regulations. So, I mean, those need to be changed then to deal with that. Now, these things are you know, if we could go through this and identify, these are things that could take place in a short space of time. No more strategies, please, about it, and no more policies upon policies. We could do this in a short space of time and change people's lives in a very small but important way. Is there anything that you could comment on and give me any idea about that, please?
I think we're all champing at the bit to get in. I think the first thing I would say is, whilst I wholeheartedly agree with you, there is a small thing called the National Legislative Framework that's in our way. It's set down by government who's eligible for free school meals, and that does not equate to the description of poverty that we've co-produced with local people. So that's why you're seeing the difference. Similarly with school transport, there's a legal framework around that which prescribes who is able to access those benefits, if you like. If it was within our gift to change it, please be assured I'd be front and centre with a placard trying to change it, because actually I completely agree with you. The challenge we have is this is national policy, so it's not so easy for us to adapt. What we're hoping to do through the implementation of the strategy is to see what local variations we can make, what we can put in place locally to support people who don't necessarily fall within the legal definitions of who's entitled to these benefits, but who we have determined with them do meet our definition of somebody who is in poverty or at risk of poverty, who we need to help there and then. And it will be catching those people to help them with their circumstances that will be so incredibly important, and where the successes will come. I know Councillor Andre wanted to.
Actually, what I've got to say actually follows on very nicely from what Laura's just shared. For the last couple of years since the issue was raised, there is a campaign called No Child Left Behind, which is actually campaigning for free school meals. I lobbied our former MP and was told he couldn't support it. Not to be deterred, I have been in touch with Joe Robertson, and he is currently, he has got back to me very promptly. He's got his parliamentary assistants looking into it, doing more research, but he is favourably minded. He does support the idea of free school meals, but he's looking into further research. But in terms of lobbying government, that is currently happening. Thank you.
Would it help, both to Councillor Andre and Laura Gordian, would it help if this committee put it on the letter you heard that we are going to write to both MPs? And if you could give perhaps this committee specific things, it would seem to me that would help enormously, not necessarily tonight, but when we write on to our two MPs, specific things that they could do to assist this. I mean, for example, I'm not sure that free school meals necessarily should be for all. It should be means tested, it seems to me. So free school meals, for example, for all those that fit our definition of poverty. So if you can set out in the letter what the definition is, and then our MPs need to know what they need to lobby for, and in other areas as well, like what you want to change in the national policy on the etc. So if we could just have, we don't need a long report, just a couple of sort of bullet points on each one, then I'm sure if this committee agrees to add it, we could add it to that letter that we're going to write to the MPs. Thank you.
Chair, if it's helpful, when I get the full response from Joe Robertson regarding his view, I'm more than happy to share that, if that would be helpful on free school meals.
If you could circulate that, Debbie, that would be great. Thank you very much.
Would only say this, Chair. We don't, no criticism of Joe, and I'm pleased to hear that he's behind this, but we don't know when he's going to be able to reply, and we don't know when his research assistant is able to reply. So I don't think, with great respect, that whilst that would be helpful, and thank you, Councillor Andre, I don't think we should hold up our letter to receive that report. just in case that was the interpretation, I think we should have the information, if possible, from Councillor Andre and Mrs. Gordian as soon as ASAP, and send our letter off ASAP as well, please.
So just to summarise, we propose to write another letter to both our MPs on the back of the poverty reduction strategy of the key elements nationally that we would like to change, and those cover the free school meals and transport, and perhaps Laura, if there's anything else that you feel would be relevant to include and circulate that with the committee so that we can write a letter. Does that sound?
Yep.
That sounds. Can I have a proposer?
Yeah.
And a seconder? And those in favour? Lovely, thank you. Okay, that passes. So that's an action. Thank you very much. Do we have? Oh yes, Councillor Drew, you had a question. And
No, I think Councillor Spinks eloquently covered some of the points I was going to raise. So.
Perfect. Okay, Councillor Ward. Oh, microphone, please. Sorry, thank
I'm going
you.
to say something controversial, but it's something that bugs me. Firstly, this is not the controversial bit. Are we as the council going to, I was going to say drive this because with our partners, because I think if we don't, how can I put it? I don't mean to say drive, but I can't think another word. But if we aren't going to lead and encourage, I think, yeah, it may fall by the wayside. I'm sure you understand what I mean. The other thing, and this is a controversial bit, is there a facility to sit down with people in poverty and actually go through their budget with them and say, well, let's see what you're spending your money on. I'm going to tell you something. Last time I bought a packet of cigarettes, it was 11 and 6. Okay. And I was 17, I think. I did some research into the cost of cigarettes recently, and I just could not believe the price. You know, it was over 20 quid for a packet of cigarettes. I thought, how on earth do people afford to do that? And I just think, but you answered my question. Yes, there are people.
Chair, I wonder if I may also take the opportunity to advocate for the work that my colleague, the Director of Public Health, is doing around a smoke-free island.
Smoke-free generation.
The smoke-free generation information is well available in the public domain and is incredibly important to us as a health and social care system, knowing the impact that smoking has on many people's health. I completely agree with Councillor Ward, and Ian will remain involved in this project moving forward. We are fortunate the extension of the Household Support Fund provides us with some additional resource that we can really target around supporting the reduction of poverty on the island, and we'll continue to do so. Ian's going to be working closely with our project management team and adult social care to ensure that there is ongoing scrutiny through our programme board of the delivery of those action and implementation plans, so that not only do we know they're there, we continue to monitor that people are actually doing what they've signed up to do.
Thank you, Laura. And also we as councillors can use this document to hold those various departments to account. And it's just, I always find it really useful having it laid out in one document, a pathway forward so that we're all on the same page. Do we have any other questions on that topic? Thank you. I just want to say a huge thank you to you and your team for producing this. It looks like an enormous amount of work, but it looks really great. And with some of those tweaks, I think it will be perfect. Thank you very much. Okay, we're going to move on to agenda point 9, Safeguarding Adults Board Annual Report. We're going to receive and consider the annual report, and who's delivering that? Is it Laura? Yes. Thank you so much for patiently waiting, Laura.
That's okay. Thank you for having me. So the report, as you've got it there, is being produced by the board, which is a body with about 20 plus members who've all contributed to the report and to the work of the board. I'm happy to take any questions you may have on the report. I think it's fair to say the work in the last year was stalled somewhat of the board due to some changes in personnel and to some gaps in personnel. But the new look board with the new chair, myself as the board manager, we're now moving forward at pace and trying to make sure the voice of the board is heard and that any learning that we're identifying is embedded in working practice. And I know Joe's on the here with us today, is also on the board and has been a huge help to the work that we do. Happy to take any questions you may have.
Thank you very much, Laura. Have we got any questions from the committee on that? Okay, I've got one. So on the workforce development subgroup, so it is mentioned here that the lack of operational oversight has reduced learning and development. Something that comes up consistently across loads of topics on this committee is about the workforce. And so I was wondering if you could sort of highlight what you perceive as other, apart from the oversight, if there's any other challenges coming forward on that topic.
So in the role of looking at safeguarding in particular, the workforce development subgroup is a group that we have in joint with Children's Partnership Safeguarding Team. And it's led by the Council's Learning and Development team, but again, it's multi-agency approach. And every year we do a learning needs analysis. So we look at what are the gaps in training, who has some expertise locally that we could tap into to share those resources, and what are the emerging themes within safeguarding that we're seeing that we need to tap into. And one of the biggest things that we consistently see is around professional curiosity. And that's about professionals asking those questions at the appropriate time and, for want of a better word, being nosy, appropriately nosy, to ask those questions to identify when there's risks and when people need intervention. And through the identification of that, there's some work we're ongoing in terms of training around windows of opportunity so that professionals can know when to spot those opportunities and then how they can progress those. But in terms of the wider workforce, it's generally around embedding the learning that we are identifying, having the resources available and the time to attend to the training and the time it takes to adopt those processes. We are monitoring, particularly around with the mergers with the NHS, any impact on that, and we will obviously see that how that progresses. But again, a changing workforce poses a risk and an issue in terms of maintaining that continuity, particularly around safeguarding. So it's something that we're working quite closely on.
Thank you very much, Laura. And do you find retention difficult in this department? Is that an issue?
That's not something that we would monitor as part of the safeguarding activity, so I wouldn't be able to comment on that specifically.
That's fine. Thank you very much. Have we got any other questions? Yeah, Joe.
I've just got a comment about the report, and it's really difficult when you come in part way through a year to then have to write the report. And I know that from experience, but it's written in a really clear and accessible way, easy to understand. So it's a really good report, which is really provides some useful information. And I just wanted to mention that you provide an awful lot of training, which we as an organisation find really useful, because the training's varied. It can be face-to-face, online. There were hour sessions of training. So it means that my staff aren't spending a whole day, but they can spend an hour learning about something that's really relevant to their role. So just wanted to thank you for the training, which we find invaluable and we wouldn't be able to afford to source ourselves. So that's, yeah, really useful and huge range of training that's been really useful to us. So thank you.
Do you mind if I just ask who that training is available for? Are there specific organisations that training is for?
So the training is available via the SAP. We have our own website and all our training availability is on there, and it's open to anybody that's working with individuals that may be at risk. So it's quite a wide reach really, and it's changing all the time in terms of what training is availability. Some of it, like Joe says, is what we call a lunch and learn. So it's just an hour session, so you can just dip in your lunch hour, and you're not having to impact too much on your day. Some of it is more involved training, but it's all there available and easy to access for.
Thank you, Laura. That's really interesting. Do I have any other questions from the committee? Thank you very much. Thank you for patiently waiting to deliver your report. I appreciate it. Thank you very much. Okay, we're going to go on to agenda point number 10, which is the work plan. So we obviously don't have many meetings left now before the end. The 3rd of March is our final meeting. Do we have any questions or queries about the work plan from the committee?
The public health informal, can we ask that that includes some overview of the joint strategic needs assessment?
Yeah, we can certainly put that to Simon to see if he would present on that. That would be a very interesting addition to the informal. Can we ask Simon to do that? Thank you. Any other comments on the work plan or any of the items coming up? Okay, thank you. Oh, yep, Laura.
Sorry, I just wonder if I can clarify. On the 3rd of March, you've got an item which is reduction in mortality rates to review what policy strategies are in place to support people to live healthier lives for longer. It's down for the cabinet member for adult social care and public health. I just wondered whether it would be possible for the committee to perhaps be a bit more specific in terms of what you're looking for. That's quite a wide subject matter, and I'm conscious that it's quite a full agenda. I know it would certainly help my colleague, Mr. Bryant, who's had to leave the call, if he could have a bit more of a direction from the committee as to what specifically you wanted to drill down to as part of that session. Otherwise, I suspect he could fill all 3 of your hours.
Thank you for pointing out Laura. Yeah, I'm sure that's something that we can provide. We can discuss that and provide a more direct and specific direction for that. Okay, thank you. If there are no other comments on the work plan, we'll just move on to members' question time. We got any questions? Yes, Councillor Downer.
Thank you, Chair. I went to that health thing down at the Riverside the other day that Mal sent through about, and I was happening to talk to the prostate cancer people, and they said that they've got to do everything by donations, and also that GPs don't test the PSA in the blood anymore. Now, don't you think that's a bit of a backward step? Is there any help that could be given to those? And I would like to ask Jo as well what her comments would be, because we did discuss this before the meeting. You know, although the measure of it, if it's not too high, they don't sort of worry about it too much, but you never know, do you? And all I'm sort of saying is that, you know, you can't shut the stable door after the horse is bolted. Thank you.
Thank you, Councillor Downer. Do you have a comment, Jo?
We do get feedback around that from people that have tried to access at their GP practice and been refused. And given the situation with Chris Hoy recently and his battle with cancer and his wish that people would be able to get diagnosed earlier, then it's certainly something that people come to us about and are concerned with, that the only way they can access this is through a local charity who have to fundraise to get this done.
Perhaps we could put that as a question to the ICB, would be the relevant body from the committee around that. I know that there are now more and more younger men being diagnosed with prostate cancer, and there is greater awareness, but with the greater awareness also needs to be more accessibility to the tests that can test for it.
Ask another question, just a comment, and not a criticism. Could Mr. Bryant speak a little bit slowly, more slowly in his delivery, because you can't understand what he's saying? Thank you.
Councillor Spink.
Just for clarification, for my lack of knowledge about this, was a blood test for PSA, was that previously available and now has been stopped? Because I understood you could. Is that what's happened? Does anyone?
So historically, we've had people go to a GP practice and be able to do it, and other GP practices won't. And there are some complexities around what the results mean. You know, it's not quite as cut and dried as other testing. However, you know, it is able to catch cancers early on. So some people would like that choice.
I mean, it seems strange because the NHS is trying to promote people going for sort of regular health checkups. And I mean, prostate cancer is one of the most prevalent male cancers or even health problems. And although, as I understand it, the blood test, the PSA test, isn't conclusive, it could be that the level is raised by other concerns, but it is a very good way of determining whether or not there should be further investigation. So I also think, with respect, that many of the traditional way of determining prostate cancer puts many men off going, quite frankly. And for that reason, it would be quite good if you could go and have a blood test, and then you only have to go through the rather more unsatisfactory way of testing if that blood test is positive. So I think it's short-sighted, if I may say so, from a number of points of view, but also from a financial point of view, because if someone has prostate cancer, then and it's already well established, it costs the NHS far more than having a blood test at an early stage.
And we're back to realistic medicine. It's around giving people the correct information so they can make an informed choice about having a PSA test. Yeah. And if they're given the right information, then yeah, they should be given the choice.
Thank you for bringing that up, Joe. That's really good to link that back to what we were talking about earlier. And it strikes me that the comparison, I suppose, is with cervical cancer screenings, where it starts at a certain age for women and then continues 2 years forever, or to a certain point. Although those two tests aren't really as comparable with what results they show, but I can imagine that there is a desire and a call out from men that there is something equivalent to help catch this. So we'll definitely take that as an action to write to the ICB and put that question around that for clarification to them. Do we have any other members' questions? Okay, well, that wraps up our meeting. Thank you very much. Thank you very much for attending and for waiting patiently to the end as well. And thank you to the committee members too. Thank you.